right, to round out the two general entities of incontinence, I'm going to be talking about overactive bladder. So previously, I talked about stress incontinence, which is an outlet issue, and now we're going to talk about the storage entity of incontinence, and when the bladder does not store properly, feel like a balloon, and it squeezes too much, essentially, and how we can treat that. So no pertinent disclosures, and this is the overview of what this talk will consist of. And so overactive bladder is defined primarily by urgency, and it's usually associated with urinary frequency and nocturia and with or without urinary incontinence. It is a chronic condition. I talk to patients like this is treating high blood pressure, and it's influenced by advancing age, race or ethnicity, obesity, smoking, diet, and medical conditions. We'll talk about that a little bit more on Friday. And it is quite prevalent. So women are affected by this. About 13% of the female population and 11% of the male population is affected by this. It represents a major economic burden and a major quality of life burden on patients as well. So direct costs include physician visits, tests, medications, interventions, equipment like pads, diapers, gloves, loss of work for productivity from frequent bathroom visits, and high cost measuring up to $65 billion. And treatment can be life-changing because it really does affect quality of life. So these are quotes from patients that I have. I feel like I'm 21 years old again, even though I do talk to patients that I'm not going to be able to give you a 25-year-old bladder again, but some patients do feel that way. And they will say, I'm a new woman. I can't believe I didn't do this sooner. And my wife is a new person. So this is the old roadmap from SUFU. This is from 2017, and wow, it is overwhelming. So this is kind of what we were instructed to talk to patients about: education and behavioral modifications, first line, second line, and third line therapies. And now this is new and improved as actually of 2025. This is the shared decision-making model that SUFU is promoting, and really it's talking to patients from the get-go and counseling from that first visit about all three areas. So non-invasive therapies, lifestyle and dietary treatment options, pharmacological therapies, and minimally invasive treatments as well. So gone are the days that we are thinking about it from first line, second line, third line, and now we are thinking more holistic, giving patient empowerment and really patient-centered care for overactive bladder. So conservative management includes reduction of caffeine, known bladder irritants, spicy foods, carbonated foods, acidic foods, and managing fluid intake is important. You don't need to drink 3 liters of water a day unless you're a stone former. And then I always talk about the role of weight loss for patients. And I really, I bring this up quite often with patients. It is a sensitive topic, but we are dealing with sensitive things. And I just talk about, it's just extra pressure on the bladder. So, weight loss will improve all aspects of life, including your bladder symptoms. And bladder training. So I talked about my love for pelvic floor physical therapists and our partnership with them. And so we utilize them to teach patients to avoid rushing to the restroom. And once they get that sudden urge, they give the 5 clicks, and then distraction strategies can be implemented. And this really can reduce incontinence episodes. So, and then we can move on to medications. So it's actually quite interesting how many patients come to me as a specialist without trying any medications. So I would encourage you to all, talk to them about these options. And so antimuscarinic drugs work on the parasympathetic nervous system, and they've been around for many years. We'll talk about that as well. And beta-3 agonists are the newer medication, have less side effects, and work on the sympathetic nervous system. So I usually try patients, recommend them to try these medications for 6 weeks, especially with beta-3 agonists. Really, I talk to them about how it reaches the peak effectiveness at 6 weeks. So really don't give up after a couple weeks. You'll see the benefit if you you stick with it a little bit longer. There is significantly poor compliance with any chronic medication or a medication to treat a chronic disease, which we'll talk about. And the OAB guidelines do discuss how you can use combination therapy with antimuscarinic and beta-3 agonists. So this study came out, it's old, it's from 2011, and it's mainly dealing with antimuscarinic therapy, but it's astonishing that 72% of patients are non-adherent at 6 months with their overactive bladder medications. So it's really important to really discuss early on that, we can't get your bladder back to when you were 25 years old. And so we do have other options that are long-term, that are more durable for third-line therapy or, minimally invasive therapy. And the problem is that anticholinergics, we know that increases the risk of dementia, estimated up to 46% versus non-users. And of course, this has always been a battle with insurance. So unfortunately, I practice in South Florida where there's lots of small different insurance companies. And, for instance, Sunshine Health doesn't cover any beta-3 agonists, which is truly a crime. But anyways, beta-3 agonists are a great alternative, have less side effects, don't cause the dementia. This is a study that top graph shows urinary incontinence episodes decreased by about 1.8 times per day, and graph B on the lower half shows that at 50 milligrams mirabegron also decreases number of micturition by 2 times per 24 hours. Vibegron also will increase the number of micturition episodes per 24 hours by about 2.4%. So again, it's also very important to characterize the severity of their symptoms. I have patients that come in saying I leak 10 times a day. So really, so 2.4 is what you would expect, and you have to counsel those patients about that to really make sure that we're meeting the same goals. And then I'll talk about the minimally invasive options. So this is a study to look at 5,500 patients that have a diagnosis of overactive bladder that came to a single institution, and 3.5% of patients were treated with third-line therapy, and really not much, minimal improvement among urology specialists that are capturing these patients with overactive bladder, and among ERPs specialists as well. So it's our due diligence to make sure that patients know about these minimally invasive treatment options. So sacral neuromodulation, the general principles are that there's a modulation of crosstalk of afferent and efferent nerves involved in the voiding complex, and this can be done at the level of S3 or the peripheral posterior tibial nerve, which comes from the sciatic nerve branch, L4 to S3. So it was developed by Tanago and Schmidt, as many of you know, in the 1980s. I do like to talk to patients about how it's been around for a long time. It really has been implemented since the 90s. And it's FDA approved for overactive bladder, fecal incontinence, and non-obstructive urinary retention, which we'll also discuss the data on that. And 87% of patients report improvement, greater than 50% improvement of their symptoms at 1 month, and have a sustained response at 5 years. It's now MRI compatible, which is something that we've been able to achieve in the past couple of years, which is great. And it does require anesthesia and requires device replacement over time or explantation. It is not known exactly how electrical therapy treats the bladder. We actually don't know that much about it, but we do know that it works. So just to kind of review neuroanatomy, sacral neuromodulation can inhibit local sacral interneurons and direct inhibition of bladder motor neurons. It may also inhibit the pontine micturition center activation, which decreases OAB contractions. And studies show that there's cortical sensory areas of the brain that are also altered by sacral neuromodulation. And this is the Artisan study depicting a rechargeable battery and the benefit. So there's 2 companies, which we'll address, that have this technology on the market. And they did show 80% efficacy of OAB symptoms. This is a 5-year follow-up study to look at the product that's been around for many years by Medtronic. And this shows that really significant. At 60 months, 80% of patients have improvement of symptoms, and 45% of patients report total cure and total continence, which is truly amazing. So I do mention that sacral neuromodulation for its other indications, underactive bladder. So underactive bladder, and one of my passion projects is detrusor underactivity, which I think we're really just kind of scratching the surface with. And sacral neuromodulation is great for that. And so even with truly with true patients in retention, studies show that success rate is not as high as OAB. However, it is still quite high. 69% of patients at 6 months are no longer cathing. Fecal incontinence. So our colorectal surgery partners and GI partners also show great improvement with this technology as well. And 79% of patients have greater than 50% improvement. I mean, this can be truly debilitating for patients. So to be able to offer this is great, and it's unaffected by presence of sphincter injury or not. And bladder pain syndrome, it's not FDA approved to treat this, but there have been studies to show improvement of pain for these patients. I mention all of these components for sacral neuromodulation because truly, most patients don't just have overactive bladder. They're presenting with many other symptoms. A lot of my older patients have a DHIC picture, detrusor hyperactivity with impaired contractility. So they're having OAB symptoms with contradictory impaired contractility or elevated PVR because of some underlying detrusor underactivity. So sacral neuromodulation can treat both of those. Neurogenic bladder, it's not FDA approved. We do have a study that University of Miami is participating with for CERN, looking at MS patients now that it's MRI compatible. And spinal cord injury, there is some suggestive articles to support its use in these patients. Spinal cord injury is difficult to study in general because of the heterogeneity, but the progression to stage 2 is variable, anywhere from 50% to 70%. So surgical techniques. So this is an AP image, and we are looking at the sciatic notch and the sacroiliac joint, and we're looking at these thumbprints. So those are our foramen that kind of march up from 1, 2, and 3, and so we want the lead to go into the superior medial aspect of the foramen, and it should travel the journey of the nerve and the course of the nerve. So this is a lateral area this is a lateral image that we're looking at, and there's 4 different programs essentially that we are looking to catch the nerve: 0, 1, 2, and 3. 0 is most distal, 3 is most proximal. So most of the time we get lower amplitudes at 2 and 3, and we're just trying to catch the nerve and see that response at 0 and 1, the more distal aspects. So we're looking for, again, medial in the foramen and superior in the foramen. Ideal response is S3 or S4. We are usually looking at motor responses in the operating room, sensory for P&Es, which we'll discuss, and we want amplitudes to be 2 or less to preserve battery life. There's various ways to tunnel to reduce infection risk. And of course, we're always looking for dorsiflexion of the great toe, bellows, and anal wink. So, historically we always previously used the initial advanced evaluation. So this is, we take patients to the operating room twice. We use x-ray guidance to place the lead, and then they're connected to a temporary battery, and they have a 1 to 2 week trial. And then if they see success, then we go ahead and just implant the battery for the second trial. Now we have utilized P&E. So this is an in-office procedure where we are placing bilateral leads to improve our success with the P&E evaluation. Usually it's not done with fluoroscopy. I do not do fluoroscopy. I use bony landmarks and measurements. And it's done a week in the clinic. And so patients just try it out for a couple of days. I mean, that's just how I talk to patients. I say, why don't we just, there's medications, or else there's other options, but you can just try it out. We'll just do a test with the acupuncture needle. We'll clean you up, do an acupuncture needle. You go home, try it out for a few days. And if you like it, then we go to the operating room. So the pros for two stages are two stages in the operating room is higher success because you're using fluoroscopy to guide your placement, and but the cons are two separate operations. I mean, during COVID, we had to do COVID, nasal testing twice to go to the operating room and all those things, and that kind of changed what we did. So for P&E, single operation, a little bit lower success rate, and so sometimes it's hard to get patients that don't do well with P&Es. Then you want to move on to a staged approach, like why don't we do it under fluoroscopy? And it's hard to get patients to kind of rope into that. However, I mean, push comes to shove, there's different reimbursements rates. So as you can see, the total reimbursement rate for work RVUs is 45 for P&E, then full implant, compared to now, this is changed really from 2022 for 13 RVUs in a staged approach. So we are kind of pushed to do a P&E trial. So postoperatively, there's continuous stimulation. You can adjust the program to improve response. And so the INSIGHT trial at 5 years showed a 20% explant rate, which is quite high. So 15% of patients had explant from site pain or ineffective stimulation. And, patients do require reprogramming quite a bit. So the burning question is, which product do you use? And I think it's just, whatever you're comfortable with. So both have rechargeable and non-rechargeable. And there's a more complex remote. So the Samsung phone for Medtronic, and then a little bit easier remote for Axonics. Constant voltage for Medtronic versus constant current for Axonics. Both are MRI safe. And both have 15-year half-life. I mean, when I think about this, I think it really comes down to region and your preference for your reps and your customer service. So there's differences with that, nuances with that. PTNS shows effectiveness, not as great as and it's not as effective, but it does require a lot of visits, and adherence isn't as good. So the dropout rate is pretty astonishing. So again, this is a chronic condition. So is PTNS really a viable option for someone that's going to be having this 5 years down the road? Probably not. But that's where implantable things come into play. And bladder chemo denervation or Botox can be done in the office. But, for me, I think, again, it's the adherence. I really second guess that compared to a battery that can last 15 years. Risk of UTI is super high. So, my older patients that also have not just OAB, but they also present with their recurrent UTIs, I think twice, and I counsel them twice a little bit longer about the risk of UTIs with this procedure. And urinary retention is, of course, there as well. So, different things are coming out. We're kind of trying to think about what we can do for PTNS to make it more effective. So longer sessions, more sessions more often during the week are other options. So the future of OAB treatment. So implantable tibial nerve stimulation. So this is an office-based procedure, no external stimulation. It's a 3-year battery life. So why do this? Why is this out here? So it's effective. It's easy to place and minimally invasive. It can be done in the office. And it's really, truly the future of OAB treatments. And why not? So, patient selection is super crucial with this. And I do think that the correct patient for this, in my talk track, when we're talking about implantable devices, either SNM or implantable tibial stimulation, I think that the patient that did well with PTNS is a great patient that can go on to implantable tibial stimulation, so that they don't have to come to your office for that 30-minute period every so often. So we have 3-year data, and I think that the stark difference is that we don't have that 20% explantation rate with implantable tibial stimulation. So complications are very low, and we do see, again, similar decrease in daily UUI episodes. So going from 4.2 to 1.7 on average at 12 months. And then it's sustained at 36 months with 75% that are responders. And we qualify responders in the OAB world as 50% improvement or greater. So this is the technique. You're looking at the medial malleolus of the ankle, and we are tunneling it. So you're making your incision a little bit cephalad, and you're tunneling it down here and to catch the nerve, the posterior tibial nerve at this location. Another new product that's on the line is implantable devices with an external wearable battery. So this is a very, very tiny also implant that's put in the office, and then you wear your ankle bracelet, and it's the previously Revi and now it's Blue Wind. So this patients are doing well with this, and we see that there's great response, and it gives empowerment to the patient to be able to do these. Be able to have treatment at home, I think, and then see all these things on their on their phones and things like that. So patients, again, you have to know your patient. Patient selection is crucial. Patients that don't just want an implant and never have to think about it again, S&M. But in patients that really like to have those numbers and really like to be involved in their care, I think this is a great option as well. So reduction of UA episodes also is great. And so in conclusion, overactive bladder really affects a significant proportion of the general population. It is burdensome. The cost is high. There is truly poor adherence to medications, and I think that really is because of the chronic nature of the condition. And we really should be talking about third-line therapies or minimally invasive therapy options from the get-go. It's exciting because for ERPs, this is the treatment area that's continuously expanding, and we're leading the charge in innovation technology with this. Thank you.